Chapter 2, Theories and Theorists. The objectives are here listed. You can read those for yourself. And the introduction, basically you guys, what we're looking at and how I want you to start thinking is you cannot think as your own personal thoughts when you are looking at your patients. You need to put on your theorist hat when you are looking at your NCLEX questions, when you're looking at your patient. Sometimes our own personal experiences can be helpful in situations, but at other times they can cause us problems. So we want to make sure that we're putting on the theorist hats. When somebody says, I want you to think like Hildegard Papelot, our nurse theorist, or I want you to think like Freud, or I want you to think like Sullivan, you need to put those hats on, especially when you're doing your board questions, so that we're causing and helping our patient develop and grow, but also for you as a nurse to grow and not stay stuck with your own personal experiences, so that we're using treatment-based, evidence-based practices. These are the terms that you need to know, be familiar with, so that you are not caught off guard in the comprehension and understanding of these elements. So we're going to start with Freud because he is the father and foundations of all our components. And he talks, and we use the word psychoanalytic theories. So basically he's the talk therapist. He's the ones that got everybody to sit down, lay on the sofa, and chat away. And so there are 3 levels of consciousness that he describes. And with this, we still use these in practices. So we have our conscious level, our preconscious, and our unconscious. With this, what we're describing is our conscious is we're fully aware of how we feel, what we're thinking, and what we're doing. And it's on our brain and here and now and in the moment. Preconscious things are things that are, you need a little something to help you bring it to the surface. It's there, but you need something to kick your memory. So if I would ask you, what did you have for dinner last night? It might have taken you a second to think about it. Or somebody else says, oh, well, I had Tijuana Flats last night and it was delicious. Or the guacamole wasn't so great. And then all of a sudden it triggered, well, yeah, we had mashed potatoes and gravy. And that gravy really was funky last night. And it starts to bring together what you had, but it took you a second or two to bring it to light, to bring it to full consciousness. But then we have another level that is the unconscious. These are memories, these are thoughts, feelings, etc. that are down below where you cannot necessarily pull them back to the surface, to preconscious or conscious. And we'll talk about defense mechanisms because that's where when we're protecting ourselves, our brain will protect us, will put things in the unconscious level. Also, you'll see on here that you have id, ego, and superego that are all on the unconscious to preconscious levels. And we will talk about that a little bit later, but I want you to be aware, well actually in a couple minutes, about what those elements are and how they're perceived and what we're doing. So here they are, the id, the ego, and the superego. And notice how I've put the little devil and the angel there, because this is the easiest way I can teach somebody how to remember this. I want you to put the devil on your left shoulder, and I want you to put the angel on your right shoulder. And I want your ego, and your id is the devil. So the devil's sitting on your left side. Your superego is your angel, and it's sitting on your right side. And your ego is your brain. It's sitting in the middle between the two. So your id is all about your pleasure principle, your reflex and actions, your primal processes. I want now, me, 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 me. Very narcissistic, very want gratification now. I want it now. So think about it as a child, okay? But we're talking primal needs. When we're talking about, and I'm going to jump all the way to the other extreme, which is your superego. your moral commitments, okay? To do right and to do wrong. We learn our superego from our parents, okay? We watch from examples, the rules that are set in the house, how we're doing things, but we want to do things right. We want to do it for the greater good, where what's right, what's wrong, what's the good thing to do. And then our ego is our problem solver. That's where we do the balance of our id and our superego to come up with the best response in the reality test. So sometimes, you know, when we talk about people are attracted to their polar opposite, and you're like, my two parents, I don't know how they do it, because mom's on this end of spending money, dad's on this end of spending money, but together they make a great balance. And that's the kind of idea that the ego does, is to bring the balance between the id and the superego. So here's a situation. You're going out, you plan to study because you got this big test on Friday, but some friends call and ask you to go out dancing tonight. And even though you're going to go out with them Friday night after that big old test, what kind of conversations would your id, your ego, and your superego have with each other? You know, oh, let's go out, it doesn't matter, everything will be fine, I can study later. Who would that be? Whose conversation would that be? Would that be the id, the ego, or the superego? If you said id, you would be right. Oh, you can't go out, we need to study, I need to be successful, all will be well, we'll be good, and have to do the right thing so I can be successful in my life. Who's that conversation? Is that the superego? And then the ego would be, of course, having the conversation, wait a minute, you two. No fun? That's going to make me boring and unhappy. And if I go out today, we're in trouble. So maybe I'm going to study for a little bit. I'll go out and meet up with everybody and for a couple hours, but then I'm going to go home and get some good sleep and do some more studying and be prepared for my test. So I can go have a little bit of fun, but not too much fun, and prepare for my test. Or the ego might say, no, we're going to, Friday's plenty of time to have a whole lot of fun then. I need to go ahead and just go study tonight and we'll be fine. But that's the kind of conversation that role play is going to have. Okay, so defense mechanisms. This is on page 20. You're going to want to know these defense mechanisms in anxiety, because this is going to be part of your anxiety chapter, your stress chapter going forward. There's a whole mess of different types of defense responses and how you're going to interact with them. So you're going to start with looking at defense mechanisms, and Freud has defense mechanisms, and Sullivan calls these defense mechanisms called security operations. So there's two types, and we're going to talk about them, but it's basically the same idea. Defense mechanisms and anxiety come hand in hand, and they operate on an unconscious level. Freud says, however, that you use your defense mechanisms to deny, falsify, or distort reality because it makes things less threatening. Okay? So for an extreme moment, it's sort of as for a situation, you're being raped. And your brain, it's too much information. It's going to be pushing things and suppressing down the information to your unconscious level. And it's saying, this isn't happening to me. And you're going to be counting the dots on the ceiling tile, and you're not going to know anything's happening to your body at that point in time. It protects you. It distorts what you're thinking, and it makes it less scary. Or say you're going to go bungee jumping off of a bridge, and this isn't scary. This is fun. There's nothing wrong with doing this at all. This is a blast and a half, even though you might be terrified. But your brain tells, and you keep telling yourself this is fun. Those are the kinds of things: deny, falsify, distort reality to make it less threatening. So then we have with Freud, and this is on page 21, he says that experiences during the early stages of life determines an individual's lifetime adjustment patterns and their personality traits. So you have oral from 0 to 1, anal 1 to 3, phallic 3 to 6, latency 6 to 12, and genital 12 and beyond. So what does this mean? So if you cannot master your ability and wean from sucking and biting and chewing, because that's what happens in your oral phase, and that of course is we're working on our trusting of our environment, then you're going to have fixations, okay? And you're going to be have passivity, you're going to be gullible and dependent on others. And you'll use sarcasm and develop oral focused habits like smoking and nail biting. So, anal phase, you're supposed to work on the toilet training, right? That's the phase that we're developing, that skill. But it's to work on having control over our impulses. So if we have difficulties being able to do that, and it could be because you're in the hospital and you're not working on being able to be successful with this, then you have a problem with developing a sense of control over your instinct drives, or being able to delay gratification for future goals, or overcoming impulses. And if you're negative, you're anal retentive, you're stingy, you're rigid thought patterns, you have OCD, you're anal expulsive. Instead of anal retentive, you're anal expulsive, meaning you're messy, you're destructive, you're cruel. Never thought of that would come into your life, did you? But those are some of those things that we have to think about. In the phallic stage, you're supposed to be working through masturbation and your sexual identification with the same-sex parent. Well, what happens if that parent isn't there? You're supposed to be developing your superego throughout those components. And so then you're going to start having identification issues. And negative, you're going to be reckless, self-assured, narcissistic personality, inability to love, difficulties with sexual identity will develop from this. Okay? So, excuse me, I hit the wrong piece to that. Yep. Okay, I did have the right piece. I just wanted to make sure. Then you have latency. Okay, and this is your growth of your ego during latency. Your social and intellectual abilities to care for others outside of the home. Your ability to develop skills to cope with your environment. And if you don't get this developed, you're going to have problems relating to others in social situations and leading to a sense of inadequacy and inferiority. And then you have your genital stage, okay? Sexual intercourse, developing satisfying sexual and emotional relationships, being able to emancipate from your parents, planning life goals and a sense of personal identity. Outcome, okay, is you should be able to create and find pleasure in love and work. But if you don't develop this developmental skill, then you're derailed emotionally and financially. You won't be able to be independent, and you're impaired personal identity and can't develop a satisfying, intimate relationship. So from these classic psychoanalytic theorists, such as Freud, things that we still use that are very relevant besides the ego, superego, and id, is that we validate the fact that it's important of individual talk sessions. We understand about active listening, and transference and countertransference are a big issue. And that nurses must be self-aware, meaning you need to know all your own issues and how you're thinking, and seek guidance and making sure that you are aware about yourself, and when you're having struggles and difficulties, to ask for help and to talk about it so that you can have more insight to respond better to your patient. I'm going to skip these questions. You can look at those yourselves and the case studies. So now we're going to move on to what's now called psychodynamic therapy. This is newer than the psychoanalytic model, because these guys here focus more on the here and now, and this starts on page 21. And they use many tools that are used during this, but the candidate that the patient, the client that you want to use for this is somebody who we call the worried well. So they're out there functioning in the world, going to work, how's the family, how's their life going, but they're sometimes doing things that are sabotaging their life, or they're having a little problem here or there, or they want to make life a little bit better for themselves, okay? They have a clear difficulty area that's difficult, but they're intelligent and they're motivated to work. And what's going to happen is there's going to be a rapid back and forth between the therapist and the patient. And the therapist and the patient have to agree to a couple things. One, there's got to be a time limit, saying we're going to have 10 sessions, an hour or 2 hours a piece of each of those sessions. We're going to focus in on this particular area, and we may look at some of your past, but we're going to see how it's currently affecting here and now. We're not going to go and dig up a whole mess of crap from your past and then not apply it to what you're doing currently in life. Okay, so this is where we might use some free associations. So I say a word, you say a word back to me, to try to start putting some pieces together. We might even use some dream analysis with this. But again, we focus back on the here and now. So an example might be somebody who's married, they're doing really well in work, and then they decide to have an extramarital affair, or and they don't know why they're doing that. Or somebody who's up for a promotion at work, but they keep doing something with their boss, like being very sarcastic, and sabotaging their ability to get that promotion. So now we're going into Sullivan, and Sullivan still starts on page 21, and it's called Interpersonal Theory is Sullivan. And the whole purpose behind Sullivan and the reason you hear the word interpersonal is because all interpersonal reactions create or reduce anxiety. So, and you try to avoid anxiety. And anxiety, per Sullivan, is defined as a painful feeling or emotion that arises from social insecurity or prevents biological needs from being satisfied. He uses the term security operation that measures the individual's ability to employ to reduce the anxiety that enhances security, and self-system of all security operations the individual uses to defend against anxiety and ensure self-esteem. So what are we talking about regarding this? So when you have an interaction, you are potentially going to have anxiety, and you try to defend against it. And there are 4 types of interactions that are potential there. There's grief, role disputes, role transitions, and interpersonal deficits. So the main goal is to improve the quality of their interpersonal relationships and their social functioning, to reduce their distress in those 4 key areas. So now we're bringing in Miss Hildegard Pablo, and that you guys have heard me talk about her multiple times, that we are participant observers, and we are mutually respect for the client, unconditional acceptance, and empathy. So going back to interpersonal relationships, let's talk and connect all 3 of these components. Then we've got Freud, who says we have defense mechanisms for anxiety. We have Sullivan, who says we have interpersonal security operations anxiety. Okay, so interactions cause the anxiety, versus Freud, who says anything can cause fear and anxiety. And then we have Hildegard, who comes in and says that we're participant observers. So when we've got Hildegard working with Sullivan, we're going to tie in then that we're going to help this person. So if somebody has grief and loss, we're going to help them with their complicated bereavement issues, their death of a loss, their divorce, their losses, or their interpersonal disputes they're having with conflict with the significant others, or their role transition issues of life status changes, their social, their vocational, their financial issues. So that's what we're doing, but we work together. We respect that patient and continue to move forward. So Pablo is the one that came up with the art of nursing. Provide care, compassion, advocacy, enhance the comfort and well-being. This is where we get to apply our personality in with our patient. Okay, she is our mother of psychiatry for mental health. Okay, she was the first nurse to identify the patient-nurse relationship in mental health. The science of nursing is the application of knowledge to understand that broad range of the human problem and to intervene in relieving the patient's suffering and to promote their growth. Now, the anxiety levels. There are 4 levels of anxiety, and how you base reading and understanding those 4 levels are based on perceptual field impairment, problem-solving impairment, and physical or other presenting behaviors. And then we work on interventions to lower anxiety to aim to improve the person's ability to think and function. This is why when somebody is in the middle of having an anxiety episode is not the time to try to teach them. This is why we want to teach that person before the episode to do their homework and to improve things. So when we are looking, and one of the things I want you to definitely do is chapter 15, page 272. Again, chapter 15, page 272, table 15.1 is going to be where you're going to find these levels of anxiety as that I'm going through. So mild is when this person's experienced a perceived reality in a sharp focus. So this is when you guys are coming in to take a quiz or an exam. You can hear and grasp more information effectively, and your problem solving excellent. You feel a little bit of slight discomfort. You're a little restless, little irritable, mild tension, okay? And you might try to relieve that tension by tapping fingers, cracking some knuckles, biting your nails, fidgeting a little bit, okay? Mild, that's mild, okay? So now moving to moderate, you have your perceptual field narrows, okay? So you're not seeing all the details now. You're only hearing and grasping pieces of information. So you have what I call selective inattention. You must point out items. So this is when I'll say in a class, okay, the following things are due by such and such date. And you'll hear one of the 3 things being listed, and you didn't hear the other 2 items that need to be picked up and done, okay? You're not thinking as clearly or problem solving as well. And your sympathetic nervous system is now kicked in, okay? And so we can see the tension, your heart's pounding, so now we have an increase in your pulse, an increase in respirations. You're probably now starting to perspire. Your GI tract is now not digesting as well, and your gastric juices are increasing, so you might have some discomfort. A headache's kicking in. You're going to have urinary urgency, and your voice and your hand starts to tremor, and you feel the need to signal that you need help. Okay? Now, severe anxiety versus panic. Severe, your perceptual field is greatly reduced. You are focused on one little detail, and you cannot notice what's going on with anything else. So, for example, have any of you ever lost a kid in a store? And your focus is finding this kid, and you are running all over the place trying to find them, but you can't see the fact that somebody's trying to stop you to find out what's going on so they can help you because you're too busy looking for your kid. This would be a good example of you not noticing anything else going on around you. Okay? You can't learn or problem solve during this point in time. You may be in a daze. You'll have a headache, nausea, dizziness. If this keeps going, you'll have insomnia. Your body might be trembling, not just hands, but your whole body might be shaking. You might have a pounding heart. You're hyperventilating and having a sense of impending doom or death. Somebody will literally say, I feel like I'm going to die, or something bad's going to happen. I know it. It's coming. It's coming. It's going to happen. And then panic is a complete dysregulation of behavior. Okay? This is where somebody's completely running around, pacing, shouting, and screaming. Or they could be withdrawn and completely isolated. They can be hallucinating even because it can be that severe. Have a false sensory perception. Become erratic, uncoordinated, impulsive. Using autonomic behaviors to reduce or relieve anxiety, such as like rocking back and forth. And it doesn't help at all to relieve it, and eventually they will become exhausted because their body will wear out from that panic. So that's what we're talking about when we're looking at these components with these levels. So now we're talking about behavioral theorists, and basically with behavioral theorists, we're talking there's an assumption that you can change maladaptive behaviors without insight into the cause. Okay, so you can change maladaptive behaviors without insight to the cause. So this is getting us back into, and I know you guys have had basic psychology already, and we talked about Pavlov's conditioning, Watson, and Skinner. So, you know, Pavlov was the dog and the bells, and when the dogs would just eventually hear the bells, they'd start salivating because they were conditioned to have food, and when they knew the food was coming, they'd start salivating. Okay, they'd have an autonomic response of the body just by hearing the bells because they were conditioned. Then you had Watson. Do you guys remember baby Albert? Okay, and what's the word I want to say? The white mouse or the white rabbit. I can't remember if it was a rabbit or a mouse now at this point. And he would be associated with loud noises because he was a nice little child that was of 9 months of age, and so every time the loud noise and the white rat, I think it was a rat, were shown at the same time the noise was done, which would startle baby Albert so that he became scared of any type of white fur. He'd start crying and run away. And so that was Watson. And then Skinner came into play, and Skinner worked on what we call reinforcing behaviors, behavior modification, and modeling and role-playing and milieu management all came around from Skinner. And we look at token economies and milieu management from him. So that was some of the big stuff with Skinner. So Skinner did the rewarding, or the, what's the other word I want to use? Aversion therapy. Okay, so if you did a good job, I would give you an M&M. But if you did a bad job, I would inflict discomfort. Okay, and we have what's known as positive reinforcement and negative reinforcement. Negative reinforcement doesn't necessarily mean that you have to hurt somebody. Negative reinforcement can also mean taking away something that someone values. Now, in psychiatric hospitals, we usually do not do negative reinforcements because of the fact that it can be abused and misused, and it does require behavioral plans, and everybody has to be part of the treatment plan. Everybody has to be very consistent when you're doing a behavioral plan, and we try to do it with positive reinforcement only versus negative. But there are times when we also use aversion therapy, but we try to, again, avoid using that if it's feasible. But there are some medications that also are used as aversion therapy. Antabuse is one of them. That's one that we used in substance abuse for alcohol abuse. So once a person is sober and they're really afraid they're going to relapse, they can take Antabuse. And Antabuse is going to cause this person, if they touch or drink any type of alcohol, they're going to become violently ill from ingesting it or having it touch their skin. So there is a lot of education that must be done to teach this person to, one, not drink any alcohol, but they need to read all the labels of any products that they're going to use for skin care, for washing their hairs, for like mouth rinse, any of those kind of things, because they cannot contain any alcohol because they will become very sick. So there's a lot of those elements that they have to be very aware of, because they're going to be bent over, severe headaches, skin's going to get flushed, and it's like going through with severe withdrawals almost to a degree. But they'll be on the floor and they will be miserable for several hours. So if a person decides, well, hey, I want to drink, they can't just stop the pill that day and start drinking that same day, because this medications can stay and there's a residual effect that can potentially last, so that maybe by day 4, maybe they'll be safe to potentially go ahead and drink without having a side effect. So starting on page 24, we talk about some other components of behavioral modification. One of them is role modeling. Again, we're back to Miss Hildegard again. Participant observers. And this was part of what I was talking about when we were at physically at clinicals, is being to group early and role modeling for your patients and how to behave and not leaving early. All those behaviors, every interaction you're doing, you're role modeling. How you swear, what you do, how you're doing it. You're that role model for that person. Even if they're 20 years older than you, you are that role model that you're trying to assist and help. Operative conditioning, again, rewards and punishment for volunteer behavior to reinforce. Positive versus negative. Negative is removing the object or an adverse stimulus. Again, punishment's an unpleasant consequence, okay? Sometimes that is a good thing to use with someone who's autistic or dual diagnosed kids with self-care tasks. Extinguishing behaviors, that's another thing that's used sometimes in operative conditioning, where we ignore a behavior and the patient stops it or the client just stops doing it. Sometimes it's best to just, and we call that extinguishing a behavior, the absence of a reinforcement. So you don't notice, so you act like you just don't notice it. They don't get a positive by noticing it, and nor do they get a negative by noticing it, because you just walk away from it. And that it allows the person not to have any power over it. And then we have what's called system desensitization. And when we're doing this, and this one gets thrown out quite often on testing, is this is very helpful for a patient that has specific fears, to teach them how to relax. And you do this by breaking things into stages. So you expose them a little bit by little bit to what they're afraid of until they can actually physically get in its presence. So, for example, say that a person's afraid of snakes. So you start with maybe showing them pictures of snakes. Then maybe increase it by showing them videos or a movie. From there, they might go to a reptile zoo and go see them behind the glass. And then eventually work up to actually being in a room with an actual snake itself where there's no glass barrier between them. And then the last piece would be actually holding and touching that snake. So little by little working it through. I've done that with people with elevators before because they're so afraid. But system desensitization. I think I've already really kind of covered aversion therapy, and I've talked about the alcohol. Sometimes we also use this for people who are violent and aggressive, self-mutilators. Let's see, people who shoplift is another one that's good. Oh, I know, just a simple one, just because it sometimes gets thrown out there. Think about somebody who sucks their fingers and you want them to stop sucking on their fingers because you don't want your kid stuck in braces and they need to give it up. And so people will put something that tastes bad on their fingers so they try not to suck it. Those would be some of those components. Epicat, for somebody who's putting things in their mouths that make them throw up instead, so avoid doing that. So those are some of those pieces that I was trying to think about. And then you've got biofeedback. Now, I've done biofeedback as a child because they used that to help me manage my pain levels. So what you do basically is you get, it's doing relaxation techniques, believe it or not, is really what it is. But you're hooked up to machinery where you can actually monitor your own physical biological responses, your heart rate, your temperature, your blood pressure. So you can physically see your changes that are taking place, and you start to slow down your body and your heart rate and increase your body temperature. And in so doing, that causes you, of course, to relax your muscles, but it makes you focus in the here and now, which is actually part of what we call DBT, didactic behavioral health, and you're focusing on the here and now moment and being in that moment instead of focusing on the pain, focusing on the things you're worried about, and allows you to relax, and that will lessen your perception of your pain. You will look in chapter 10, page 164. There is a massive list of relaxation techniques that are there to help improve those your relaxation techniques there. So now we're moving into cognitive behavioral therapies, which that's what we practice a lot of with our patients. The whole idea behind cognitive behavioral is to not focus, let's see. We work on increasing or decreasing measurable behaviors, but we don't focus on the thoughts or the cognition that are behind the behaviors. We want them to just make the change, okay? So, with cognitive behavioral, and this is on page 25, there's a dynamic interplay between the individual and the environment. And we know that thoughts come before feelings and actions. Thoughts about the world, our place in the world, are based on our own unique perspectives, which may or may not be based on reality. So I just put this little thing here. Well, I made it through the day without having to beat anyone to death with a chair. I'd say my people skills are improving. And why did I put this little statement there? Why is this there? Well, this is because how you see your world is based on your unique experiences. And again, we are going to ask you to put your theory hats on when you're working with your patients. So if you have had a horrible childhood and you see the world through angry eyes, okay? And the world is an angry place and a horrible place to be in, okay? So your response to everything in the world is through anger and hitting somebody with a chair, then you're going to say, my people skills have improved. Now, if you were raised and you see everything through rose-colored glasses and the world is a beautiful place to be in and there is nothing wrong in the world at all, then you're going to be seeing it through those rose-colored glasses and can't see that there might be some evil that's out there. So each person is unique. And because of that, we can distort how we respond to it because we already have a feeling of what it's going to be before we have a thought of what it's going to be before we even have the feelings. So your first instinct is when the work comes to you, I can't do it. It's too much. And you haven't even looked at it yet to even find out. Because you're already feeling and have thoughts of being overwhelmed. Even though that may not even be for that particular work, the thoughts are already there. So those are those things that we want to have people to do. And this is, of course, on page 25. So with cognitive behavioral therapies, we have what we call rational emotive behavioral therapy. And the best way I can do this is that we do the ABCs, okay? So this is a therapy where somebody, you oughta, you should've, you done, and then you're negative thinking all the time, and it's irrational. You must be a part of, you shoulda, you coulda, you oughta, okay? You think like that all the time. So we do the ABCs, activating beliefs, okay, activate the belief, C, emotional consequences. So ABCs, activating the beliefs, emotional consequences. Do you see the glass half full or half empty? How do you view going to a party? Is it exhausting and fun, or is it too much work? Those are those kind of things. How do you see it? We got to change those things, okay? So you aim to eradicate the irrational belief and recognize that thoughts are not always accurate. Okay, CBC, cognitive behavioral therapy, tests distorted beliefs to change the way of thinking. So autonomic thoughts and then cognitive distortions. So this works best with somebody who has depression or anxiety, is negative and self-critical, okay? And so what we want to do is have the person determine their thinking and their place in the world are irrational and lead to false assumptions. So when somebody says, I'm stupid, I can't do nothing right, okay, we're going to have this person change what they're thinking and have them rephrase it. Okay, so there's a lot of rephrasing of their thoughts, or otherwise known as reframing their statement. So, I didn't do as well on the test as I'd like. Oh, so instead of I'm stupid and I can't do this, I need to study a little bit more. I didn't do as well on my test. So it's changing how they're thinking by having them reframe what they're saying. And if you look on page 27, because these are the most common cognitive distortions, and these are the ones that can show up on your tests, your HESIs, and your NCLEX exams. Okay? So there's things such as catastrophizing. For example, if you don't make a good impression on the boss at the company picnic, she'll fire me. Catastrophizing. Is that really a true statement? Is your boss really, if you can't make a good impression at the company picnic, they're going to can you? Now, if you really get intoxicated at the company picnic and make a fool of yourself, will you have a poor impression of yourself with your boss? Yes. But will that cause you to get fired? I don't think so. But will you be watched a little bit more closely? Probably. Or the all or nothing thinking. Although Lindsay earned the second highest score in the state cheerleading championship, she consistently refers to herself as a loser. Because I came in second, I'm a loser. All or nothing. If I can't be the number one, I can't be it at all. Or the overgeneralizer. I had a minor traffic accident. He's reluctant to drive and say, I shouldn't be allowed on the road anymore. I can't do it. Okay? So all those pieces, jumping to conclusion, mind reading, fortune telling. So take a look at those. Make sure you're familiar with those components to be ready for things. And then we have didactic behavioral therapy. And again, this one is getting into so this one is just a modified form of CBT. They started using this with people who had borderline personality disorders. It's basically to help somebody manage their, I guess I want to say their emotional responses better, so that they're not hurting themselves as often. I guess that's the best way of how I can word this. How could I do this? So it's working on relaxation techniques. It's working on being in the here and now. This is where somebody will say to someone to, let's go hug a tree right now. Literally, go hug this tree. I want you to smell the air. I want you to take your shoes off. I want you to walk on the grass at this moment in time. I want you to be in the here and now. I want you to get out of your head and your thoughts and be in this moment that you're in. not worrying about the past, not worrying about the future, but be here and working on accepting and tolerating the distress that somebody's in. Because people have distress, and what they do is that you'll get more and more anxious and you stay in your head, and the more you isolate and the more that you pull away, the more then you have the thoughts ruminating over and over and over in your head, and you become more and more uncomfortable, and then that increases the risk of harming yourself. This has been very good with people who have depression, bulimia, binge eating, bipolar disorder, PTSD, and substance abuse. So it helps to help themselves to manage their emotions more. Okay? So nursing interventions that we do, a lot of reality testing, correcting those distortions and this is what we're doing under the cognitive behavioral therapy. Teaching to challenge their own negative thinking, substituting with positive rational thoughts. So I'll go, rephrase that, reframe it, try it again. And homework, they've got to practice. Everything we have them do, they need to be practicing. Okay, so this is where the lovely little post-it notes. I usually tell people who have a lot of negative self-thoughts, and as this term has progressed on, and especially this past week with us switching over, if you have post-it notes at home, I want you to go and everything that you have been thinking or saying that have been negative. I'm not going to succeed. I'm dumb. I'm not going to make it. I'm not going to pass. I want you to go on a post-it note and reframe it. I'm smart. I'm intelligent. I can do this. I will pass. I am going to be an RN. And I want you to start putting them on the mirror in the bathroom, on the refrigerator door. And every time you see that post-it note, you say out loud to yourself whatever is on that post-it note. The more you say it over and over and over, you will then start to believe it. And that's part of the stuff that we have our patients do. And some households are loaded with post-it notes. This is something you can even do with your children. If you find your kids are doing a lot of negative self-talk already, it's time to start teaching them how to do the positive self-talk. Because once you start doing it, you start believing it. Without even needing to understand why you're doing it, you just start doing it. So now we're getting into our humanistic theorists, okay? Those are the ones that you have the potential and free will to choose your life pattern. Support a personal growth and work on self-actualization. Oh my goodness, who are we talking about? Who could that possibly be? What I want to talk about is self-actualization. There is a section, it's on page 29, box 2.1, and it talks about what a self-actualized characteristics are of a self-actualized person. They're creative, especially in the management of their lives. Pleasure in being alone and an ability to reflect on own events. Active social interests. Mystic or peaked experiences. Moments of intense ecstasy similar to religious or mystical experiences during which a self is transcendent. They may become involved in what they're doing and lose all sense of time and awareness. Their light-hearted sense of humor that indicates we're in it together and lacks sarcasm and hostility. Fairness and respect for people of different races, ethnicities, and religions. Acceptance of themselves, others, and nature. Not defensive in their perception of the world. Okay, There's a whole list of many other components that are there. But I want you to take a look at that. And there's another piece in your book in here that talks about some examples of people who are self-actualized. And the reason I bring this up is because I want you to make sure that you could recognize examples of somebody who is self-actualized through statements. So that will be on an upcoming exam and potentially on your HESI. Okay, humanistics. Now that you've identified the personal struggles you have in working with this patient, we're going to skip that. Never mind. Okay. So we have a biological models of things that cause mental illness a little bit here. Neurological, chemical, genetic, biological, okay? And how the body and brain interacts to create emotions and memories and perceptions. We've all talked about this already, okay? So we are a lot more aware of the antipsychotic drugs, thorazines of the world, or lithium, that gave insight on how some people can be free from psychosis and mania, okay? So we know that there's biological pieces to this. But also that it plays a role in the development of mental, social, environmental, and economical components. So we have to focus in then, while we're doing the biologicals, the quality of therapeutic relationships, understanding the patient's perspective, communicating, facilitating the recovery, and medication management. Because if the medicine's going to make them too sick, and we don't understand that patient's perspective and try to offer something different, they're not going to get better. It's better to just stay sick than to take the medicine, because the medication is going to make them feel horrible. So we have to look at that and help make that balance happen. Pharmacology, and then of course we've got the brain stimulation components. And you'll also see these in the depression chapter. Okay, but we've talked about ECT, we've talked about transmagnetic stimulation, vagal nerve stimulation, and deep brain stimulation. Those all help and assist with depression. So we have our developmental theorists, Piaget. So we have, with Piaget, we've got the sensory motor stage, pre-operational stage, concrete stage, and formal operation. I'm not going to go in big details of those. You need to know what they're doing and what they're supposed to be. Object permanence. When is that supposed to happen? When is the patient supposed to, age-wise, develop and move from concrete thinking to abstract thinking? And with somebody with schizophrenia, some of the patients cannot go, or they lose their ability to abstract think, and they are only able to concrete think. What does concrete thinking look like? So if I ask the person, are you feeling blue today? And the patient responds back, where am I blue at? What is that evidence of? Concrete thinking? Here's those stages here in a short little graph of being able to look. But make sure you're familiar and you know these elements, okay? The next one is Erikson's stage of development. And with Erikson, along with Freud, when we don't develop these stages, we can have problems in our adulthood having relationship issues. Sorry, I had to grab a drink there really quick. Okay. So when we're talking about this, what am I talking about then with our lovely, lovely kids? So if we aren't getting our trust, mistrust, so if we're unsuccessful developing it, we're going to be suspicious as adults, fear of our future, and you might hear an adult say, I can't trust anybody, ever. because I can't depend on them when I need them. Okay? Versus an adult or an older kid saying, Mom and Dad are supposed to be picking me up, but they're running a little late, but they sit there and they wait for them because I know they're coming. Because their trust-mistrust stage has been met. Okay? Autonomy is, you know, again, their ability, their sense of self-control is there, and they know I'm adequate, and they'll have willpower. Okay? And initiative. They initiate their own activity and have a sense of purpose versus being aggressive and fearful. Industry, having the sense of success and being competent or not. Identity, this is who I am, this is what I want to be. I can stand independent of others. Otherwise, what's going to happen is we're in gangs and we cannot make our own decisions. Intimacy, love, and deeply committed versus being self-egocentric. Generativity, giving and caring of others versus after work I stay home and all I do is watch TV and I don't care about anybody else but me. And then you end up alone and isolative. Integrity, fulfilled, willingness to face death and realizing I've had a purpose in my life. And you don't worry about that that the conflicts you've had in your life. You find peace. And I see that they pull generativity out a lot because how do you talk to an older adult to make sure that they're there? Or do they still have hang-ups with their parental relationships and find fault at things? Where are they at? So look over table 2.6 on page 31 and look at the examples of the positives and the negatives of being successful with reaching these stages. Okay. Let's see. I have these other developmental theorists there, theories of object relations and progression from black and white thinking to complex decisions. Just because these can occasionally show up, I don't see it a lot, but I wanted you to just be aware because these are things that can show up from growth and development elements. And then the stages of moral development and ethics of care theory. Okay, so just be aware those are on page 32, table 2.7. And then you have the development theories in nursing, okay, and your assessments. And that's it for this. There's a couple questions through this element. If you are weak in your developmental theories and the foundations of psychiatric mental health, go to your Saunders book, edition 7, and hit chapters 21, 22, and chapter 68. Those are probably some of the big ones that you would want to look at. And how can you know if you're not too strong? On that is every time you take a HESI and it shows that you're low on your developmental scores, that tells you you need to go and get that done. Have a great day.